All right, well, I think we're going to go ahead and get started. It looks like everybody has pizza. I'm pleased to introduce our speaker today. Our speaker today is Dr. Daniel Jackson. He is a fourth-year resident here in our program, and he will actually be graduating in April. Dr. Jackson did his undergraduate and his medical training here at U of L. Unfortunately, even though he's had a long stint here in Louisville, we're not going to be able to keep him. He is headed to Washington, D.C. To work as an adult outpatient psychiatrist when he finishes up. So many of you might know that Dr. Jackson expressed a pretty strong interest in advocacy work early on in his training. I remember him talking to me about this when we were interns together, and I was just trying to figure out how to manage patients, and Daniel had much bigger dreams. So during his residency, he's served on the Advocacy and Policy Subcommittee of the GLMS. He's also served multiple terms as the KPMA representative, the resident representative, and he sits on the KPMA Legislative Committee. He's attended Advocacy Day in Frankfurt, and he's also attended an Advocacy Leadership Conference in Washington, D.C. Most notably, Dr. Jackson was awarded a really prestigious fellowship. He was awarded the APA Gene Spurlock Congressional Fellowship, which he completed in 2015 to 2016, which is why he's a little bit off cycle for his training. So during his 9-month fellowship, which I think we're going to hear about today, Dr. Jackson aided in drafting healthcare legislation pertaining to Medicare, and was able to provide recommendations in regards to health policy. So again, I think we're going to hear a little bit about his fellowship experience today, in addition to his Grand Rounds topic, which is Inside the Beltway, a history of federal mental health policy and legislation. So I will let Dr. Jackson take it away.
Thank you, Dr. Reese, for that introduction. So I'm presenting today Inside the Beltway, a history of federal mental health policy and legislation. And Inside the Beltway is just a popular term used to describe governmental matters. And personally, I've always had an interest in policy and politics. And early on in my training here at the University of Louisville, I began looking at ways to integrate my interest in policy and politics with my interest in mental health matters. And this started with advocating for the Greater Louisville Medical Society, as well as the Kentucky Medical Association, the Kentucky Psychiatric Medical Association. And this transcended into advocating on a federal level for the American Psychiatric Association. And ultimately, I was fortunate enough to receive a fellowship through the American Psychiatric Association, where I worked in Washington, D.C. for 10 months in a congressional office doing health policy work. And so when I was thinking about topics for my Grand Rounds discussion, I began to realize that we don't really get any formal education in regards to health policy and in particular mental health. So today I'm going to talk about a history of federal mental health legislation as well as weave in some of my health policy experiences. I have no conflicts of interest or financial disclosures. The learning objectives today are to learn the history of U.S. mental health policy and legislation, gain insight into the congressional fellowship experience, and learn ways to get involved in advocacy. So prior to the opening of the first mental hospital in the United States, the primary goal was to decrease trouble caused by the mentally ill. Patients who didn't cause much trouble were relegated to the countryside, and patients who committed crimes or posed a threat in some way were at risk of being imprisoned in the local jail. Francis Fakir is an interesting gentleman. He served as Virginia's acting rural governor and chief administrative officer from 1758 until 1768. He was born and educated in England and was influential in arts and business before immigrating to Virginia. And once he came to Virginia, he struggled with the illegality of imprisoning the mentally ill as well as the lack of treatment for them. And before coming to Virginia, he had witnessed some of the publicly run hospitals for the mentally ill that had been present in France and England for over a century. And he proposed a similar idea be implemented on American soil. The House of Burgesses was the first legislative assembly of elected representatives in North America. And Fakir went to this assembly in November of 1766 and spoke of what he described as a poor, unhappy set of people who are deprived of their senses and wander about the countryside. He proposed a hospital staffed by physicians who would treat these patients, and apprehensive at first, the legislators eventually conceded. And in 1770, 2 years after the death of Fakir, legislators adopted an act to make provision for the support and maintenance of idiots, lunatics, and other persons of unsound minds. Construction began 1 year later. The public hospital for persons of insane and disordered minds was the first public mental hospital in the United States and opened in 1773 in Williamsburg, Virginia. And this hospital had aspects of both jail and hospital in its design. And initially, treatment was far from ideal and today considered brutal. And during this period, in regards to mental illness, some people believe patients chose to be irrational, and common medical treatments of the time were unpleasant in hopes to dissuade patients from their choice of irrationality. This is just a recreation of a 1773 patient cell. Initially, the hospital had 24 cells, and cells were reminiscent of prison with barred windows, board doors, and chains fixed to the walls. And cell furnishings consisted of a straw-filled bed on the floor, a blanket, and a chamber pot. And this is just a few of the treatments that were used during that time period. On the left, you'll see lancets, which were used to bleed patients to remove harmful fluids. Scarificators in the center were bloodletting tools with a spring-loaded mechanism that snapped the blades out through slits to pierce the skin. And on the right, you'll see cupping glasses, which doctors press the warm glass against the patient's skin to bring blood to the surface. This is Utica cribs, and Utica cribs were used to restrain out-of-control patients and were often stacked one on top of the other with patients inside of them. And this is a tranquilizer chair designed by Dr. Benjamin Rush, considered the father of psychiatry, and at the time believed madness was an arterial disease, and the chair was supposed to control the flow of blood toward the brain by reducing motor activity, thus reducing the force and frequency of the pulse. And this was believed to be essential in the successful treatment of the mentally ill. Dorothy Dix was an important figure in the mental health movement. She was born in Hamden, Maine, but moved to Massachusetts at age 12 to escape abuse from her alcoholic father. And in 1841, she witnessed terrible treatment of inmates, particularly those with mental illness, while she was teaching Sunday school at a local jail. And being affected by what she had witnessed, she subsequently traveled across the state to research conditions of the mentally ill in prisons and poorhouses. And in 1843, she crafted the document that she presented to the Massachusetts legislature and persuaded them to open or expand their state hospital for the mentally ill at Worcester. And upon this success, she traveled about the country, again researching the poor treatment of mentally ill individuals, and played a direct role in opening 32 additional mental health hospitals. And her work led to the proposed federal legislation, the Bill for the Benefit of the Indigent Insane. So the Bill for the Benefit of the Indigent Insane was introduced in 1853 and was the signature initiative of Dorothy Dix. And this would have established asylums for the mentally ill via federal land grants to the states. And this bill would have set aside 12 million acres of federal land, 10 million acres for the benefit of the mentally ill, and the remainder to be sold for the benefit of the mentally ill, with proceeds distributed to the states to build and maintain asylums. This bill passed both houses of Congress in 1853, but was vetoed by President Franklin Pierce, who argued that the federal government should not commit itself to social welfare, which he believed was the responsibility of the states. And to many historians, this is considered landmark legislation and established a precedent for federal non-participation in social matters for over 70 years until the New Deal of the 1930s. And of note, there was no further federal legislation on mental health for over 90 years until 1946, when the National Mental Health Act was passed, which we'll talk about a little later on. Clifford Beers was the founder of the mental hygiene movement. He grew up in New Haven, Connecticut, and was a successful businessman who had graduated from Yale University. And while at Yale University, he experienced what many described as bipolar disorder, with severe ups and downs along with paranoia. And this culminated in a suicide attempt in 1900 when he dropped from the third floor of his family's home And he didn't sustain severe injuries. He had some minor cuts and bruises to his feet, but he subsequently spent 3 years in various psychiatric institutions. A mind that found itself hit the shelves in 1908 and is the autobiography of Clifford Beers, and it detailed the brutal treatment that he experienced and witnessed while at these institutions, which included being locked in a padded cell for several weeks and placed in a straitjacket for several hours at a time. And upon its release, this aroused a storm of protest and public concern about the care of people with mental illness. And to many historians, the modern mental health movement can be traced to this publication. And in 1909, he founded the National Committee for Mental Hygiene, now named Mental Health America, to improve treatment of the mentally ill. The U.S. Public Health Service in 1930 was established the Narcotics Division, later named the Division of Mental Hygiene, which brought together research and treatment programs to combat drug addiction and the study of causes, prevalence, and means of preventing and treating nervous and mental disease. Dr. William C. Menninger was a psychiatrist, and interestingly, he chaired the committee that produced the Medical 203, which revised the way of classifying mental disorders. And this document heavily influenced the first DSM. He co-founded the Menninger Foundation in 1919 with his father and brother, and the Menninger Foundation was revolutionary at its time and consisted of a clinic, hospital, and training institution for psychiatrists. And for many years after its opening, the school was the largest school of psychiatry in the country. He eventually left this foundation for an appointment with the United States Army. And during this time, there were massive shortages of mental health professionals, and the understanding of the causes, treatment, and prevention of mental illness lagged behind other fields of medical science and public health. Dr. Menninger, along with other fellow psychiatrists at his time, called for federal action. And the result was the National Mental Health Act, which was signed in 1946 by President Truman. And this bill was largely inspired by the poor record of military mental health during World War II, the poor performance of the VA, and vocal demands by veterans and their families for services. And this act amended the Public Health Service Act to provide for research relating to psychiatric disorders and to aid in the development of more effective methods of prevention, diagnosis, and treatment. And of note, this is for the first time in history, it created a significant amount of funding for psychiatric research and education and led to the creation in 1949 of the National Institute of Mental Health. The Mental Health Study Act of 1955 was authorized by Congress and called for an objective, thorough, nationwide analysis and reevaluation of the human and economic problems of mental health, and was the basis for the historic study conducted by the Joint Commission on Mental Illness and Health called the Action for Mental Health. So, mental health hospitals began growing in disfavor in the post-World War II era, and this was for a variety of reasons. One was the large patient population, as more patients were being admitted and discharged. Operational costs were perceived as being out of control. There were reports of abuse and neglect that were becoming more widespread. And there was an increased availability of nursing homes, which could assume some of the state hospitals' long-term care function, as well as the discovery of Thorazine in the early 1950s, which greatly improved the condition of those with psychosis. The Action for Mental Health in 1961 is when the Joint Commission was tasked with creating a blueprint for a system of localized mental health services that did not include a large psychiatric facility. And it assessed mental health conditions and resources throughout the country and recommended designs for systems of care and treatment intended to allow the downsizing or closure of state hospitals. And this report commanded the attention of President John F. Kennedy, who established a cabinet-level interagency committee to examine the recommendations and determine an appropriate federal response. The result was the Community Mental Health Act of 1963, which was signed into law by President Kennedy. And President Kennedy himself had a sympathetic perspective in regards to mental illness. His sister Rosemary suffered from intellectual disability and was institutionalized at an early age, and she received a prefrontal lobotomy in 1941, which left her permanently incapacitated. The bill itself provided grants for the establishment of local mental health centers under the overview of the NIH, And the NIH also conducted a study involving adequacy and mental health issues. And the purpose of this act was to build mental health centers to provide community-based care as an alternative to hospitalization. And this led to rapid deinstitutionalization of the mentally ill. The intentions of the community mental health movement were threefold. First, it was thought that by moving the locus of service delivery from the hospital to the community, that patients could be discharged and thereby decrease the census of state hospitals. It was also believed by many that patients could bypass the hospital altogether and receive treatment and support services in the community setting, and that this relocation of patients and services would decrease cost of care, which had almost exclusively been a cost burden to the states. And soon after, other policies followed which incentivized community health treatment. So the Community Mental Health Act had many problems, and the most significant of them was money, or the lack thereof. So only approximately half of the proposed centers were ever built. None of the centers were fully funded and did not provide money to operate them long term. States saw this as an opportunity to close expensive state hospitals without spending some of the money on community-based care. And this led to an increased incidence of homelessness and incarceration among mentally ill patients, which still stands today, as currently the three largest public mental health providers are correction systems: LA County in California, Rikers Island in New York, and Cook County in Illinois. The Social Security Amendments of 1965 created Medicare and Medicaid, which provided federal health insurance to the elderly and the poor. And Medicaid incentivized community-based treatment by offering higher reimbursement rates for community-based care and excluded payments to mental health institutions, which many of you may know as the IMD exclusion, which was intended to ensure that states, rather than the federal government, would have principal responsibility for funding inpatient psychiatric services. And Medicare implemented the 190-day lifetime limit for psychiatric hospitalizations. The Community Mental Health Center Act amendments of 1965 extended construction and staffing grants to mental health centers, provided grants for facilities that serve those with alcohol and substance use disorders, and provided grants to support the initiation and development of mental health services in poverty-stricken areas. And a new program of grants was established to support further development of children's services. But despite this, problems persisted. The result of these policies was confusion and disorganization. So in the 1970s, the mental health system contained a variety of institutions. There were short-term mental health hospitals, state and long-term institutions, nursing homes, residential care facilities, community mental health centers. The list goes on and on. And superimposed on this was a lack of any unified structure of insurance coverage, which again forced many patients with serious mental illness to survive in homeless shelters, on the streets, and in prisons. In 1977, President Jimmy Carter established the President's Commission on Mental Health, and First Lady Rosalind Carter served as the honorary chair of the commission. And this commission was tasked with reviewing the mental health needs of the nation and to make recommendations to the president as to how best to meet those needs. In 1978, this commission sent its report to the president, and they had a few findings. One was that many groups continued to receive inadequate care, notably persons with chronic mental illness, children, adolescents, and older Americans. And rural areas in particular lacked services. And services that did exist ignored the differing cultural and linguistic traditions of varying groups. And damage that resulted from poverty, unemployment, and discrimination could not be overlooked. It also stated that personal and community supports had to be strengthened, and a responsible mental health service system had to be created that provided the most appropriate care in the least restrictive setting. And it urged the Department of Health, Education, and Welfare, now Health and Human Services, to develop a national plan for phasing down and, where appropriate, closing large mental hospitals. And any future national health insurance program had to include benefits for emergency, outpatient, and inpatient care. The Commission also supported a series of actions, which included creation of an advocacy system to represent mentally ill individuals, prohibition of discrimination, requiring states to review their civil commitment and guardianship laws, individuals caught up in the criminal justice system should be given access to relevant mental health services, as well as increased funding for research and training. The result was the Mental Health Systems Act of 1980, which was signed into law by President Jimmy Carter, and its purpose was to restructure the federal community mental health center program by strengthening the linkages between the federal, state, and local governments. And this act promised grant programs mandated for community mental health centers to assist in expanding services, which included an expansion grant for the severely mentally ill, grants for non-revenue producing services aimed at expanding education and consulting needs, and included consumer input and involvement in services and treatment. And here's just a short clip of First Lady Rosalynn Carter talking about her experience working with mental health in the White House and the ultimate outcome of the Mental Health Systems Act.
I got upset with the press too because they covered my mental health work the first few meetings I had. And then they never showed up anymore. And one of the things I wanted to do is bring attention to the issue and how terrible it was and what few services there were. And thinking just getting it out in the public. That's what I did in Georgia, developed a good program in Georgia, by the way. But they just didn't come. And so one day I was walking in the downstairs floor in the White House and met this woman who was one of the press people. And I said, nobody ever covers my meetings. She said, Ms. Carter, mental health is just not a sexy issue. and that I didn't like. But I never did get very much coverage for it. But we toured the country, found out what was needed, developed legislation, and passed the Mental Health Systems Act of 1980. It passed through Congress 1 month before Jimmy, as he says, was involuntarily retired from the White House, and the incoming president put it on his shelf, never implemented it. It was one of the greatest disappointments of my life.
Okay, so as First Lady Carter stated, Ronald Reagan defeated Jimmy Carter in 1980, in part running on the promise of reducing government waste and regulation and returning the responsibility of many social programs to the states. A year later, in 1981, he signed the Omnibus Reconciliation Act, which repealed the Mental Health Systems Act and replaced it with the Alcohol, Drug Abuse, and Mental Health Block Grant. And this consolidated the alcohol, drug abuse, and mental health programs into a single block grant, and states were given wide discretion in how to implement this grant. A year later, in 1982, the federal funding for this block grant was reduced by 30%, which resulted in severe reductions and in some cases, elimination of programs within the community mental health centers. And this increased fees and reduced staffing at the community mental health centers led to long waiting lists and decreased service quality. The Mental Health Planning Act of 1986 established case management as a distinct benefit under Medicaid, and Medicaid amendments to improve mental health coverage of community mental health services were implemented, and it expanded clinical services to the homeless. And the Alcohol, Drug Abuse, and Mental Health Administration Reorganization Act of 1992 abolished the ADA, MHA, and research components of NIAAA, NIDA, and NIMH, rejoined NIH. And components of each of these became part of the new agency, the Substance Abuse and Mental Health Services Administration, which we know as SAMHSA. And the Health Security Act of 1993 was an unsuccessful attempt for universal health care during the Clinton administration and would have provided coverage for all Americans, including coverage for mental health services. So in the 1990s, consumer advocates began pressing for benefit parity at the state and federal levels, framing the issue more explicitly as an anti-discrimination measure. And so mental health parity is essentially providing the same level of benefits for treatment of mental illness that is provided for the diagnosis and treatment of other medical diseases and conditions. And historically, healthcare insurers have excluded mental health benefits from coverage, And if covered, patients were subjected to higher copay per mental health visit with limitations on the number of visits allowed. And many of these policies contained carve-out provisions, which is essentially providing coverage for treatments by specific types of providers like social workers and psychologists, and impose time limitations on their treatment. This increased advocacy led to the passing of the first parity law, which was the Mental Health Parity Act of 1996, which was signed into law by President Bill Clinton. And its intent was to close the gap between mental health and medical insurance coverage. And it prohibited insurers or plans serving 50 or more employees from setting lower annual or lifetime dollar caps on mental health benefits than for other health benefits. And it did give some patients some protection from bankruptcy. And this bill is credited with increasing the profile of the parity issue, which prompted some state legislatures to approach a more comprehensive parity law. Despite this, the Mental Health Parity Act was largely seen as a symbolic change due to its limited scope, and it didn't address the limits insurance plans apply to coverage of mental health services, including the number of treatment visits, days of treatment, co-pays, and deductibles, and did not cover the treatment of substance use disorders. And health plans circumvented the law by tightening restrictions on the number of hospital days and outpatient visits for mental health services. In 2003, President George Bush commissioned the New Freedom Commission on Mental Health, and its objective was to conduct a comprehensive study of the United States mental health service delivery system, including both private and public sector providers. And it recommended 6 goals in order to improve health delivery and outcomes. The first being that disparities in mental health services are eliminated, mental health care is patient and family driven, Americans understand that mental health is essential to overall health. Early mental health screening, assessment, and referral to services are common practice. Excellent mental health care is delivered and research is accelerated, and that technology is used to access mental health care and information. George Bush signed the Medicare Modernization Act in 2003, and the most important provision in there was the implementation of Medicare Part D, which was a program to subsidize the cost of prescription drugs and prescription drug insurance premiums for Medicare beneficiaries. And this included coverage of antidepressants, antipsychotics, and anticonvulsants. The parity issue again resurfaced with the signing of the Mental Health Parity and Addiction Equity Act in 2008, and this superseded the Mental Health Parity Act of 1996. And essentially it closed some of the loopholes left from the first act regarding treatment limits, cost sharing, and network coverages, and applied to substance abuse as well as mental health treatment, and continued to apply to employers with greater than or equal to 50 employees. The Affordable Care Act was signed in 2010 by President Barack Obama and is the most significant overall of the United States healthcare system since the passage of Medicare and Medicaid in 1965. And a few of its key provisions were the creation of health insurance exchanges, Medicaid expansion to 138% of the federal poverty level for individuals under 65, new regulations preventing health plans from denying coverage for pre-existing conditions, as well as the individual mandate. And there were a few provisions in there that were kind of specific to mental health. Most importantly was its inclusion in the essential health benefits. So essential health benefits are essentially a set of benefits which insurance plans must cover for people. And the ACA described 10 categories of essential health benefits, including outpatient and inpatient care, pediatric services, preventative and chronic disease management, maternity care, emergency rehabilitation and laboratory services, prescription drugs, as well as mental health and substance use disorders. And essentially, it expanded on the Mental Health Parity and Addiction Act of 2008, most importantly by including it in the essential health benefits, but it also clarified that parity must be applied at all treatment levels and specified that insurance plans must be consistent across treatments for physical and mental illness when considering what is medically necessary. The Helping Families in Mental Health Crisis Act of 2015 was the signature bill of Representative Tim Murphy, Republican from Pennsylvania, who's also a psychologist. And this bill passed the House but died in the Senate. And it would have created the Assistant Secretary for Mental Health and Substance Use Disorders, increased funding for research and evidence-based treatments, mental health crisis intervention, expansion of the Assisted Outpatient Treatment Grant Program, creation of a national stigma reduction campaign, potential changes to health privacy laws, as well as modifying Medicaid to better cover mental health services. And the Comprehensive Addiction and Recovery Act of 2016 was signed, and its purpose was to improve treatment access, grant funding for overdose reversal drugs, educate healthcare professionals on opioids, research into neonatal abstinence syndrome, grant funding for pregnant women, and educating young athletes on the risk of opioids. And lastly, here's the 21st Century Cures Act, which was signed into law in 2016 and incorporated many aspects of the Helping Families and Mental Health Crisis Act, including reforming SAMHSA by creating Assistant Secretary for Mental Health and Substance Use Disorders, grant programs for states with assisted outpatient treatment, efforts to decriminalize mental illness by assisting individuals with severe mental illness transitioning out of jails and prisons, and increased funding for research. It also clarified that Medicaid is to permit same-day billing for the provision of both primary care and mental health services, and designated $1 billion in grants for states over 2 years to fight the opioid epidemic. It also made some changes to the FDA drug approval process, which was a huge point of contention with opponents of the bill, and it was intended to expedite the process by which new drugs and devices are approved by easing some of the restrictions. And opponents of this bill fear that this may lead to public harm. So now that we talked some about the history of federal mental health legislation, I wanted to talk some about my fellowship experience. And as I said before, early on in my training, I began looking at ways to integrate my interest in policy and politics with my interest in mental health matters. So here is my intern year at the Kentucky Psychiatric Medical Association Advocacy Day. And at that time, we advocated for research on medical marijuana use and the implementation of medical review panels. And this is just a cutout from the Psychiatric News in 2014 when I went to the American Psychiatric Association Advocacy Leadership Conference in Washington, D.C. And at that time, we were advocating for increased funding by the NIH as well as the Helping Families and Mental Health Crisis Act. And once I came back from that experience, I continued to be involved with the Greater Louisville Medical Society and the Kentucky Medical Association. And our program director at the time encouraged me to apply to the Congressional Fellowship through the American Psychiatric Association. And so I just kind of applied to it on a whim, and fortunately I was chosen, and in 2015 I was selected as the APA Gene Spurlock Congressional Fellow. So the APA Gene Spurlock Congressional Fellowship is a 10-month fellowship in Washington, D.C., where the fellow is introduced to the structure and development of federal and congressional health policy. And you help develop legislative proposals, track and analyze legislative initiatives, brief members of Congress and their staff, and interact with their constituents. And during this fellowship, recipients also have the opportunity to interact with health policymakers in advocacy and professional groups. And I would be remiss if I didn't mention the person for whom the fellowship was named. Dr. Jean Spurlock was born in Sandusky, Ohio. She's the first of 7 children, and after a negative experience that she had being treated for a broken leg, she was convinced of the need for more caring doctors. She is a graduate of Howard University School of Medicine, and as a physician, educator, and writer, she made significant contributions in focusing the medical community's attention on the stresses of poverty, sexism, racism, and discrimination that affects women, minorities, gays, and lesbians. And she served as Deputy Medical Director of the American Psychiatric Association for 17 years. So, from the time that I was actually selected for this fellowship to the time I actually began working, I only had about 2.5 months. So, as you could imagine, it was fairly hectic. I had to break my lease here in Kentucky and figure out where I was going to live in D.C. and make arrangements with the residency program. And among all of this, I was also working a lot with the governmental relations people with the American Psychiatric Association to figure out where exactly I was going to work. And what I did like about it is they don't just stick you in an office. So they really try to tailor it to you so you can get the most out of your fellowship experience. So what they did was they initially asked me would I prefer to work in a Democratic or Republican office. And once that was determined, they reached out to congressional members, ones that had historically been more sympathetic to mental health issues, to see if they could accommodate a fellow during that time period. And the ones that responded positively, they set up interviews, and I went to each congressional office and met with the congressional staff and the congressman, and then I made the ultimate decision on where I wanted to work. So the first office I interviewed in was Paul Tonko's office, who's a Democrat from New York and represents the Albany and Schenectady areas. And he serves on the Committee on Energy and Commerce and the Committee on Science, Space, and Technology, and was involved in the passage of mental health parity in the New York State Assembly as state representative. Kirsten Gillibrand is a junior U.S. Senator from New York, and she serves on the Committee on Agriculture, Nutrition, and Forestry, Committee on Armed Forces, Committee on Environment and Public Works, as well as the Special Committee on Aging. And she's one of the Senate's most vocal advocates regarding mental health and the opioid crisis. And lastly, and the one I chose to work in, was Jim McDermott. He's the U.S. representative from Washington State, representing the Seattle areas. And he's a psychiatrist as well. He graduated from the University of Illinois College of Medicine and also received his psychiatry training there. And he received his fellowship training in child psychiatry at the University of Washington in Seattle. And he served in the U.S. Navy Medical Corps as a psychiatrist during the Vietnam War. And he serves on the Committee on Ways and Means and was the ranking member on the Subcommittee on Health. And I chose his office for several reasons. One was the fact that he was a psychiatrist. I wanted to learn more about his perspective being a psychiatrist as well as being a lawmaker. Secondly, I really liked the congressional staff members. Everyone seemed nice. They had a great camaraderie, and I thought I would fit in very well there. And lastly, I was very intrigued by his placement on the Ways and Means Committee and being the ranking member on the Subcommittee on Health. So the Ways and Means Committee has jurisdiction over all taxation, tariffs, and other revenue-raising measures. And it also has jurisdiction over Social Security, Medicare, unemployment benefits, enforcement of child support laws, foster care, and adoption programs. And because of this wide jurisdiction, Ways and Means is seen as one of the most important committees in regards to its impact on policy. And the Subcommittee on Health deals with bills and matters that relate to programs providing payments for health care, health delivery systems, and health research. And as ranking minority member, my boss was the highest ranking Democrat on the subcommittee and generally acted as the party's main spokesperson on the committee for matters to the chairman. This is where I went to work every day. This is the Longworth House office building, and it's one of 3 office buildings used by the House of Representatives. And the other 2 were the Rayburn and Cannon House office buildings. And it's located on the south side of the U.S. Capitol, directly across the street. And this is an aerial view of Capitol Hill just to get a better visualization of where I was working. On the right is the north side of the Capitol where all the Senate offices reside. To the bottom of the screen is the east of the Capitol, and you see the Supreme Court and Library of Congress. And then to the left is the south side where you'll see Longworth House office building in between Cannon and Rayburn buildings. So each representative can have up to 18 staff members, and the McDermott office had 8 permanent staff, which included the chief of staff, which she was the highest ranking staffer and was kind of involved in some of the policy initiatives. The communications director, who served as the liaison between the congressman and national and local press. The office coordinator, who managed official accounts and was involved in scheduling. We had the foreign policy advisor, who obviously advised on foreign policy matters. The legislative coordinator, who responded to some of the constituent complaints and comments, as well as a few other legislative initiatives. And then we also had the legislative assistants in tax, transportation, and health, who are essentially experts in their area, and they monitor legislation, help draft legislation, and make recommendations regarding their policy areas. And obviously, I spent a lot of time working with the health legislative assistant, as well as several interns and fellows that rotated in and out of the office. So my responsibilities, so daily I would meet with constituents and advocacy groups, and if there was something particularly important that I felt the congressman needed to hear, I would prepare memos regarding these encounters and provide them to the congressman. I would research legislative proposals and aid in drafting of legislation and interact with staff from other offices. And two to three times weekly, I'd attend meetings and briefings. And briefings are essentially when an expert on a specific topic comes to the Hill and gives a lecture to help keep staffers abreast of whatever issue they're discussing. And I would attend hearings as well, which committees hold hearings on policies or measures that may become law, as well as provide staff presence at various events, and occasional assistance with speech writing. This is one of the hearings that I attended, and was a hearing on the president's budget proposal presented by then Health and Human Services Secretary Sylvia Burwell. And to the left there is the civil rights icon John Lewis, who I was able to interact with several times during my time there, which was pretty exciting for me. And this is Dr. Lewis Wade Sullivan, who is the former HHS Secretary in George Bush Sr.'s administration, and he's also the founding dean of the Morehouse School of Medicine. And he came to the Hill to give a lecture on the state of healthcare. And when time permitted, I was also able to go to non-healthcare related hearings and briefings. And to those who don't know, this is the infamous Benghazi hearing featuring former Secretary of State Hillary Clinton. And I was able to be present for 7 of those 11 hours. One of the rules that they had during that hearing is if you left the room for any reason, be it get on the phone or use the restroom or go eat, then you couldn't return to the room. So I was able to make it 7 hours, and I couldn't last any longer. So, and next, one of the hot button issues during the time that I was there was the potential for Guantanamo detainees to come to U.S. facilities. And I was interested in that topic, but wasn't too knowledgeable about it. So there was a little bit of extra time in that day, and so I went to that hearing to hear what they had to say about it. And next is a short clip of the Patrick Kennedy interview. So Patrick Kennedy is a former U.S. congressman and the son of the late Ted Kennedy, and he has struggled with mental health and substance abuse problems most of his life. And during my time there, he published a book describing his experiences and reached out to our office wanting my boss to interview him for publicity for the book. So one of my tasks was to formulate a list of questions for the congressman to ask Patrick Kennedy during this interview. And this is just a response from Patrick Kennedy kind of describing mental health stigma and growing up with a mother with alcoholism.
I mean, I grew up around it. You know, I write about in the book how my mother had really debilitating alcoholism. Everybody knew it. It was written about everywhere. I mean, for her age, she was as well known or more than Betty Ford as being an alcoholic. I mean, it was Joan Kennedy. There was plenty of stories written about her. And yet we kept it under wraps as if it was some big secret in our house. So people would come and visit. My mom would walk through the house absolutely debilitated from alcoholism, and no one would look at her, no one would talk to her. It was kind of like the people that we all walk by in Washington, D.C., and we don't look at, we walk by, and it was the same thing except it's my mother, okay? And so I got that message. You don't want anybody to talk about these issues. Like, I was like everyone else. I was frozen in place, wait until my mom goes back to her room, shut the door so there's no more embarrassment. And that's how, you know, we all felt the grip of shame. We're outsiders looking at her and thinking, oh my God, the Kennedys, there's Joan Kennedy's, you know, drunk. I mean, God forbid anyone would say that. She has a physical illness, but we felt the shame around it. Now, I don't understand that, but it was real. I mean, I had that same fear that my mom would be exposed, even though everybody knew she was suffering as an alcoholic.
So interestingly, I was able to staff the congressman at this event and met Patrick Kennedy and was on the other side of the wall in the green room watching this interview occur. So I know this might sound a little rudimentary, and we've learned this in elementary and middle school, but I wanted to talk a little bit about how a bill becomes law. And for those who don't know, that's just schoolhouse rock, and I was about this close from putting it in the presentation, but I opted against it. But I do highly recommend it. So how a bill becomes law. First, you have an idea for a bill, obviously. Once you have an idea, you have to comb through past legislation, current legislation to see, okay, has anything like this been introduced or passed? And if so, does something need to be modified in relation to this bill? Once that occurs, you confer with stakeholders. So stakeholders are essentially anyone that can be affected by whatever bill you're trying to introduce. This could be patients, hospitals, insurers, anyone that could be affected. You reach out to representatives for these groups to kind of get input from them. Once that occurs, you work extensively with the Legislative Council. And so the Legislative Council are attorneys staffed on the Hill who you work with quite extensively to help put your bill in the nice legal format that it needs to be in. So once you get your bill in a nice, pretty package, then a member of Congress officially introduces the bill in Congress by becoming the bill sponsor. And one of the things you want to do is you want to elevate or increase the awareness or support for your bill. And one of the ways to do this is by having other Congresspeople sign on to your bill as a co-sponsor. And the way to have that done is we as staffers reach out to these various offices and talk to other staff members and kind of explain the provisions of the bill and encourage them to have their boss sign on to our bill for support. Now, once this occurs, in the House, bills are officially introduced by placing them in a special box known as the hopper, and in the Senate, a bill is introduced by placing it on a presiding officer's desk or by formally introducing it on the Senate floor. And a bill clerk assigns the bill a number, and House bills begin with HR, and Senate bills begin with S. Once it's introduced, the bill is then sent to the appropriate committee, and at this committee, there's hearings and debates and possible amendments to this bill. And at the end, there's a vote. And if it's tabled or they vote no, essentially the bill dies and nothing else happens to it. If it's approved, then it then can be sent to the subcommittee where there's a more detailed analysis of this bill, and again, with debates and hearings and possible amendments. And if it's approved, then the bill is reported. And that's when the bill is released from the committee along with the report explaining the provisions of the bill. It's then up to the Speaker of the House or the Majority Leader who decide what bills reach the floor and when. Once the bill reaches the floor, you have debate on the matter and then a vote. And if it's passed, then it's then sent to the other chamber. And what usually happens is, so let's say a bill passes the House but is sent to the Senate. Once it gets over to the Senate, you also have hearings and debates and possible amendments. And what you end up having is a bill that's similar but different from the original bill in the House. And you need one bill to send to the president to sign. So that's when a conference committee comes into play. So if there are different bills, then representatives from both the House and the Senate come together and they sort of iron out the details of the differing bills to make sure that there's one cohesive bill that they can send to the president. And once it's sent to the president, it becomes law, obviously, if he signs it, or if it's not signed within 10 days while Congress is in session. It also becomes law if the president vetoes the bill and is overridden by a 2/3 majority in both the House and the Senate. The Medicare Dental Vision and Hearing Benefit Act of 2016 is one of the bills that I worked on during my tenure in D.C., and this bill would have amended the Social Security Act to provide Medicare coverage for dental, vision, and hearing care. And with respect to such care, the bill established special payment rules and limitations and co-insurance requirements. The Helping Hospitals Improve Patient Care Act of 2016 is another bill that I worked on during my time there. And it's a bipartisan bill, and it was sponsored by Health Subcommittee Chairman Pat Tiberi, as well as my boss, Jim McDermott. And this would have increased access to care in rural communities by extending the Rural Community Hospital Demonstration Program for 5 years, which is essentially kind of changing the payment structure for the small rural hospitals. And it ensures the implementation of new payment policies, protected access to quality healthcare choices for seniors, and improved support for hospitals that provide care to cancer patients. And this bill passed in the House but died in the Senate. And this picture, which I was pretty proud of, is so my boss, Jim McDermott, gave a speech on the floor of the House, and in it he mentioned my name along with a few other congressional staff members for helping in our coming together of this bill. And just a few of the current mental health legislation that's going on is the Connect for Health Act, which exempts mental health services from geographic requirements for coverage through Medicare, and grants the Secretary the authority to authorize the inclusion of telehealth services and bundled payments in Medicare. And the CHIP Mental Health Parity Act, which clarifies that parity requirements apply to all CHIP plans. And recently, Governor Bevin threatened to terminate Kentucky's expansion of Medicaid eligibility should a court decide to invalidate the waiver imposing work requirements for Medicaid recipients. And there is some concern that this will affect those suffering opioid addiction in Kentucky. And a bill that was proposed last year but died but had a provision in it that we should be watchful of should it decide to resurface. Last year, the American Health Care Act proposed legislation last year to repeal Obamacare, and one of the provisions in this bill sought to remove mental health substance abuse treatment as an essential health benefit for insurance companies, with plans to leave that discretion up to the states. So what can you do? So on a local level, there's the Greater Louisville Medical Society Policy and Advocacy Subcommittee. And for those who are GLMS members, there's a Meet with Legislators event tonight at Angel's Envy Distillery from 7 to 9 p.m. where you can meet with some of the state legislatures to discuss health issues. On a state level, there's the Kentucky Medical Association Physicians Day at the Capitol on February 7th in Frankfort, Kentucky, as well as the Kentucky Psychiatric Medical Association, along with the American Psychiatric Association. And on a federal level, you can call your senator or representative. And this might sound cliche, but they definitely take that seriously. I can say from working in the office, we kept tallies of constituent calls that were for or against a bill, and the ultimate result of those tallies weighed heavily in the congressman's decision-making. And if planning to go to D.C., you can arrange a meeting with your congressional staff member. I met with people all the time that were constituents in town and wanted to discuss various health issues. So I'd like to say thanks to the University of Louisville Department of Psychiatry, my friends and co-residents, and special thanks to my family, Dr. Mary Helen Davis, Dr. Jerry Lynn Wickman, Dr. Joyce Spurgeon, Dr. Alan Tasman, and Dr. Sarah Johnson, who really encouraged me in my fellowship experience. And questions? That's it. Nothing? Hmm? Yeah. Huh? Mm-hmm. 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 Yeah. Um, I'm I'm not certain yet. I do know once I move to DC, my plan is to get involved with the DC Medical Society, and since I'm right there, probably the Virginia and Maryland Medical Societies, and just kind of see where it goes. I don't have really a set agenda right now, but I definitely want to implement that in my career. I thought about that. I would consider it in the future potentially, but not now. Hmm? Um, I think I think what I don't know if it's necessarily like a sticking point, but what I really realized, I knew there was contention between the differing parties when I went there, but once I went there, it was really kind of disheartening when I I would reach out to other offices to try to have collaborative effort, and they would either just not call, like not answer the phone, or respond poorly and not want to take meetings. And that was pretty consistent with staff from the opposite party. And I'm sure that happens in other Democratic offices. We were very receptive, but I was very surprised by that. Mm-hmm. 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 Yeah. Mm-hmm. Yeah. Well, you know, I, you know, I can't speak to like current legislation regarding that, but I can say, you're all right. There's a lot of cost involved in healthcare, and specifically in Medicare Part D, which one of the provisions in Medicare Part D is that the government cannot negotiate prices for their medications with these pharmaceutical companies, and the VA can. And if you look at it, the VA, I think, spends approximately 50% less on their prescription drugs in the Medicare program, even though the Medicare program is the largest insurer of prescription drugs. So, I think that right there is a big thing that we need to look at. And in regards to cost, without getting too political, um, for me, what I value and what I see as like a measure of how great a country is how we treat like our sickest and disenfranchised. And to me, like spending $30 billion on a wall could be better spent toward healthcare services. So I think it's a matter of where you place your priorities. Hmm? Oh, yeah, he did. Yep. Yeah, yeah, he's great. Oh, thank you. Thank you. Thanks. Thank you. Are there, mhm, 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 mhm. Yeah, I heard about that. I haven't read into it much, but I heard that it just came out, so I'd be interested to know. Mhm, mhm. Mhm. Thank you. Thank you. Mhm, 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 mhm. Um, right. As far as my hope right now, I don't know. I mean, I'm a hopeful person, but sometimes it looks a little bleak. Um, but as far as the structure, I definitely couldn't answer that question about years from now what would be done. But I definitely think number one, like we talked about, like with the cost with Medicare insurance premiums, as well as this concept. I think one of the things with the community mental health movement, like one of the problems was they kind of mistakenly stated that essentially people who are severely mentally ill, they don't need to be treated in the hospital, and really tried to force people out. And I think from our practice, we know that some people that are severely mentally ill need a longer course of treatment. And I think really increasing that awareness and changing the structure as far as health insurance programs and that sort of thing, as well as strengthening the community mental health approach, could be beneficial.